Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to all the audience, respected audience. So today I will be discussing about a very important topic, which is obstructive sleep apnea diagnosis and management. Okay, so as we all know, obstructive sleep apnea is a major underdiagnosed despite its massive prevalence. Estimated about 80% of cases remain undiagnosed and untreated. Okay, and then what are the mechanisms for this obstructive sleep apnea? So if you all can see this diagram, so what happened, this is the cycle that kills. Okay, so when we start sleeping, then the onset of sleep, then we start to have decrease in upper airway muscle tone, and then at this time patient will have obstructive apnea or hypopnea, and then the oxygen will drop, hypoxia, and elevation of the carbon dioxide. This will also increase the ventilatory effort. Then patient will awake, arousal. Okay, patient will wake up, and then the obstruction relief, then started to have increased oxygen and also carbon dioxide drop. Then patient will resume sleep again. So this cycle happen throughout the night, again and again. So that's the problem with obstructive sleep apnea. Okay, obstructive sleep apnea or OSA is characterized by repetitive episodes of partial, which is hypopnea, or complete, or we call it apnea, obstruction of the upper airway during sleep. Okay, this results in negative intrathoracic pressure, hypoxia, and sympathetic nervous system, such that fragment sleep quality. If you can have a look at this diagram, so this is normal breathing. So when we have a normal breathing, air will enter from the nose down to the lungs. But what happens if patient have partial obstruction? The airway will become narrowed. This is what causing the snoring, the noisy breathing. Then if the tongue fall backwards and close the airway, this is when patient will have complete obstruction of the airway, which is also known as apnea. Okay, what are the common clinical red flags? First is loud snoring. As most of the OSA patient, about 94% will have a snoring, and usually described as disruptive, intermittent, or gasping. Next is witness apnea. Partners observing the patient stop breathing or choking during the night. Third is daytime somnolence, means that excessive sleepiness despite enough hours in bed, leading to the fatigue and also accident. Okay, so how do we diagnose someone to have sleep apnea? Okay, so we have a stop bang questionnaires. Okay, this is the stop bang questionnaires. So S is for snoring. So we ask patient, do you snore? Okay, next is tired. Means that patient often feel tired, fatigued, or sleepy during daytime. Third, O is observe. Someone observe patients having stop breathing. Fourth, blood pressure. So we ask patient, do they have hypertension, high blood pressure or not? Fifth, BMI. BMI more than 35 or not. Then age, is it more than 50 or less than 50? Seventh, neck circumference. The neck circumference, is it greater than 40 centimeter? Gender, is your gender male? So the patients considered as high risk of sleep apnea if they answer 3 or more questions yes. Then lower risk if they answer less than 3 questions yes. Next, we also have the pictorial sleepiness skills. This one, the pictorial sleepiness and sleep apnea skills, in which we ask patient whether they feel very sleepy during sitting and reading, during watching television, sitting quietly after a meal, and also as a passenger in a car. because this will determine whether the sleepiness very high or low. Okay, so how to establish the diagnosis? Okay, we need to do sleep study to diagnose patients having sleep apnea. So usually, this sleep study, there are two types of sleep study. Type 1 is the patient doing it at in the hospital setting, where we will measure EEG, EOG, EMG, ECG, and also respiratory effort. The second type is home sleep testing. Yeah, this is category type 2 to type 4. This is unattended sleep in the patient's home. Okay, this is more reliable because we can do it at home setting. Next, how do we classify someone having sleep apnea and the severity? So based on the sleep study, the amount of apnea plus the hypopnea divided with the total hours of sleep will give this apnea-hypopnea index. If normal, 0 to 5, mild 5 to 15, moderate 15 to 30, and more than 30 events per hour is considered as severe OSA. Okay? Besides that, in the sleep study also, we can also see the other parameters such as the total snoring episodes, the oxygen level, the lowest SpO2 oxygen during sleep, and also how many obstructive symptoms per minutes, per hours, and also per second, and in what position. Is it during patient's supine position, or turn to the left or to the right, or prone position? So that's very important because we need to know in details. Okay, so what are the treatment or management of this OSA? First is, of course, weight loss and also lifestyle modification, because even 10% reduction in body weight can lead to a 26% decrease in the apnea-hypopnea index. Okay, second, positional therapy. Usually this is for patients who have mild OSA, as we ask them to avoid the supine position, because every time patients lying supine, the tongue will fall backwards and narrowing the airway. And then also habit modification, such as avoidance of alcohol and sedatives before bedtime. Okay, so next is positive airway pressure. Positive airway pressure, also known as CPAP, continuous positive airway pressure. This is the gold standard for moderate to severe OSA. It acts as a pneumatic splint, to keep the airway open. Okay, by using this CPAP, it can reduce the cardiovascular mortality by 27%, improve the neurocognitive function, and also alertness. Okay. Next is, we also can have a few alternative treatments, such as first, mandibular device. Usually depends on the patients. This is the oral appliances that advance the jaw forward and ideal for mild to moderate OSA. Third, we also have surgical intervention. So surgical intervention usually for patient who we diagnose having obstructive site of obstruction, such as inferior turbinate hypertrophy, tonsillar hypertrophy, that causing the airway to reduce during sleep. Okay, so why is it very, very important for us to diagnose OSA and also to treat? Because OSA, if untreated, it may lead to hypertension, cardiovascular, increase the risk of myocardial infarction, metabolic disease such as type 2 diabetes, and also increase the risk of motor vehicle accident up to 2 to 3 times. Okay, and also it also can cause stroke and sudden death. Okay, so what we need to do to increase the awareness? Screen, diagnose, and also treat, because early intervention in OSA saves lives and restore quality of life. Thank you.